Welcome back to the Mayo Clinic Cardiovascular Podcast Series, Interviews with the Experts. I'm your host, Sharon Hayes. I'm a non-invasive cardiologist and vice chair for faculty development and academic advancement for the Department of Cardiovascular Medicine here in Rochester, Minnesota. And today I'm joined by Dr. Stephen Kopetsky, who's professor of medicine in the Preventive Cardiology Division, where he serves as an expert in lipid management and lifestyle here at Mayo Clinic in Rochester. Welcome, Steve.
Thank you, Sharon.
Today, our topic is the secrets to achieving coronary artery disease regression. One of the holy grails in cardiology, since as long as I can remember, is what we do to not only prevent cardiac disease, but to cause regression of the plaque that's already been laid down. Today, we'll be talking about where we are in that science, including which patients and what type of plaque we might be able to affect. How do we assess plaque regression, and what evidence there is as to the best way to achieve plaque regression? So, Steve, give us a little background about the different types of coronary plaque. Which ones should we worry about, and which ones are most likely to regress with interventions?
Well, Sharon, the CT scans for coronary calcium have been done for, 20 plus years, and that's one we tend to focus on a lot. But that's the scar. That's the scar within our lumen of our coronary artery. It doesn't really correlate with stenosis, and it doesn't really change. I mean, it's just there like the scar you have on your hand since third grade. It's not going to change, and you're not going to die from it. But with it, the ones that also won't change are the fibrotic plaques. Not quite calcified, but they're not changeable. But the ones that really can change are the low attenuation plaques, the lipid-rich plaques, the ones with necrotic cores in them, things like that. So basically, it's the lipid plaque, which is somewhat malleable, and which is the one that usually will be associated with rupture.
So we also sometimes call that the vulnerable plaque, right? And it's associated with inflammation. And sometimes when I'm explaining to patients of how their plaque ruptures, I talk about that really scientific term, the gunk that's inside of it, right?
Yeah.
So that's the one you want to talk about regression today.
Exactly right.
So you can look at this with a glass half empty or full, because you've just told us about two types of plaque we aren't going to really intervene or be able to have much effect on, other than preventing it from progressing.
Maybe.
But what's the best way to assess coronary artery disease regression?
Well, the initial studies were done with intracoronary ultrasound, which is a very invasive test. But now, in recent years, the CT coronary angiogram has really filled in a lot. And a couple of the studies, like the Advanced DK and the Reveal plaque studies, have shown us that CT angiograms give us the same information that intracoronary ultrasounds can give us. And that means they can tell us what plaque is made of, which one is the more vulnerable plaque based on its lipid content, its low attenuation. And that's what we can actually follow now with CT scans. CT scans can also give us an FFR, a fractional flow reserve, which tells us kind of the pressure gradient across the lesion if it's significantly tight. And that's also a predictor.
So if I'm going to order a coronary CT angiogram, do I have to ask for them to characterize the plaque? Is this commonly, maybe it is at Mayo, but if I'm out in the community, does the average radiologist, is that been a trend, or is there a gap there?
Well, what is coming is AI for plaque reading in the CT coronary angiograms. And that is coming out. We're using it here. Other institutions, larger institutions, are using it. It actually will give you a total plaque burden. It'll give you the attenuation, low attenuation plaque information in addition to the FFR. So we're going to be getting a lot more information in the coming year or years that will be automatically generated by AI.
Now that we know that there's vulnerable plaque, or there's plaque that may be approachable or regressible, what is the best way to go about trying to do that?
Yes, that's a great question. And like you say, it is the holy grail, what everybody wants to do. Doc, can you just make my arteries new again? And we can't quite do that, but because the calcified and the fibrotic plaque will stay, but we can really help lower the risk of plaque rupture when focusing on the low attenuation plaque. In all the studies that have done this successfully, and one of the first ones was the DISCO study, where everybody was basically on statins. And one group, they also gave them like a DASH, which is a Mediterranean diet with low salt, and physical activity. And also they got their LDL down, but they found that the ones that were just on statins alone without the lifestyle, they had about a 20% regression of plaques that could regress. The ones on both statins and the lifestyle, the diet, the physical activity, had a 50% reduction in plaque. So that was quite significant, quite beneficial.
So have any of these studies, I presume if you stabilize the plaque, these studies have shown fewer acute events in addition to the regression. How about symptoms? Obviously, if you're exercising more, you probably feel better, but in terms of angina, has that been looked at?
It has been. It's not as hard of an endpoint, obviously, as revascularization, myocardial infarction, et cetera. It seems to make a difference, but the studies haven't been followed that long, a year or two maybe. I think if we followed it longer, we'll see a significant difference in some of the symptoms too.
What do you see in this space? Because we now have powerful enough lipid lowering. We have evidence that lifestyle is important. What are some of the next thing, either scientific questions or things that we should be doing, advising our patients, tests that we should do to assess this? And I guess a second question is, how important is it to me as a cardiologist to know if the CAD is regressing? Is it enough to know I've done all I can by getting their LDL down and got them to exercise?
Yeah, that's a very good question. And this idea, doc, just give me the statin so I can eat what I want. That doesn't work. That's not true, unfortunately. So all the studies that have actually achieved good regression and reduction in events have basically done two or three things. One is they've done the obvious. They've, worked on the smoking, worked on the LDL, get the LDL below 55. The Glagoff study, which was a very elegant intracoronary ultrasound study, showed us that once you got an LDL below 55, almost all the plaque that could regress did regress, 90% of it. The next thing they do, take care of the blood pressure, take care of the diabetes, do the obvious. The next thing is work on the lifestyle. And it's not, just adhering to the statin. It's also eating as healthy as you can, the Mediterranean or the DASH. Being physically active, extremely important. Almost all the studies, starting with Ornish's lifestyle heart trial over 20 years ago, worked on stress. And said you need to reduce your stress. Why? Because it's a pro-inflammatory. It also is related to how well we adhere to our lifestyle changes. So all these studies have really looked at multiple things. Take care of the obvious, get the LDL below 55, and really work on the lifestyle. Now that will help you in many ways, as you're aware. One thing you can do is track it. We're tracking some patients that have like left main lipid-rich plaque, which is not particularly tight. It's not a flow-limiting lesion like 50%, which of course would call for a revascularization, but less so. And you can see it actually, improve over time with the CTA, with the CT angiogram.
Last question, outside of a research trial where we're really measuring regression, is there any guidance on the role of repeat coronary CTA just to follow this? I guess I asked this because that was a big question when we were just doing coronary calcification, and we found that, if anything, even if the patient was better, sometimes they had more calcium because we put them on a statin. Any advice you can give us, at least for now, realizing we probably don't have a lot of data on a lot of guidance that's evidence.
Yeah, the last CT guidelines that came out a couple of years ago kind of hinted at it, but had no direct recommendations. Now, there have been a couple of recent studies in the last year, the advanced EK, the plaque reveal studies that have actually followed these patients. And, every year or two, you don't see much change before that's meaningful. But in a year or two, it's starting to be quite reasonable, especially in higher risk lesions where there may be left main, proximal LAD, higher risk patients. I think it's something that's coming along, and we'll certainly learn more about it. But it's very reasonable, and it gives the patient something to work on.
Thank you so much, Steve, for joining us. It is exciting. I just remember when we were, way back, and you probably remember when we were doing quantitated coronary angiography, trying to prove regression, and how difficult that was and tedious. And the fact that we've got new tools, both to measure, but also to really achieve success, is really great now. So thanks for sharing that with us.
Thank you for having me.
So this wraps up this week's episode of Interview with the Experts. I'd like to thank Dr. Kopecky for joining me today and discussing this truly important topic. We look forward to you joining us again next week for another Interview with the Expert. Be well.